Good morning and good evening, fellow doctors and colleagues. For today's Dr. Sheng-Po host retirement virtual webinar, we are honored to introduce Professor Alfredo Pontejos as our invited speaker. Professor Alfredo Pontejos completed his residency training at the University of the Philippine General Hospital, the largest training hospital in the country. He continued his postgraduate training in head and neck surgery under the guidance of Professor Sir Donald Harrison at the Royal National Throat, Nose and Ear Hospital, London, and at the Institute of Laryngology and Otolaryngology, University of London. Professor Alfredo Pontejos is currently the director of the Philippine Board of Otolaryngology Head and Neck Surgery, a council member of the Asia Pacific Thyroid Society, exclusive council member of the Asian Society of Head and Neck Oncology, and an advisor to the Asian Association of Otolaryngologic Societies. Today's Professor Alfredo Pontejos presenting topic is a classification of neck dissection, a better one. Please give a round of applause to welcome Professor Alfredo Pontejos.
Yes, thank you, Peter. And yeah, this is yes, for a while. Yes, these are pictures of my good friend Professor Sheng-Po. This first one was last year in Nashville, Tennessee, in American Academy, and this was Barbara still here in one of the American conferences, and also this one. And this is when we gave an honorary fellowship to Peter in Manila. I call Peter or Sheng-Po as a man on a mission. Okay, so well, it doesn't move for one. Okay, there. Okay, my topic is classification of neck dissection. Is there a better one? That is the outline of my lecture, history, why we do neck dissection, when do we do it, classification of neck dissection, surgical anatomy of the neck, and a conclusion. So way back in 1800s, Kocher, Billroth, von Langenbeck, von Volkmann described what we call the surgical lymphadenectomy. And in 1888, Jaudinsky described a detailed resection of the neck, the first successful one for neck masses in the neck. Now, in 1906, Dr. George W. Kreil presented the concept of radical neck dissection, and in 1953, Hayes Martin published an article on radical neck dissection, which is an unblocked resection. In the 60s, Osvaldo Suarez popularized what we call the functional neck dissection. Of course, that term is not hardly used now, except maybe in Latin America. And then Ettore Bocca, Cesar Gavilan, and Richard Jesse propagated functional neck dissection, from which the selective neck dissection evolved. Now, why do we do neck dissection? Spriano mentions that neck node metastasis represents the single most important factor influencing the outcome of a patient with cancer of the head and the neck. And this is according to Vulgar. Despite the quality of current imaging modalities, risk of occult metastasis in the neck, categorized as NO, is still between 20 to 30%, maybe a little bit less now. And Professor Myers always mentioned that the neck kills. This is just one study. This was in 2023 by Takamura, and he compared, the diagnostic accuracy of identification of lymph nodes in the neck. As you can see, the sensitivity is not as high. What does it mean? So MRI is only 44%, ultrasound is 50%. The highest is PET-CT with 77%. That means that if you have something lighting up or showing up, the highest would be 77% chance that it is a metastasis. But the specificity is very high, except in PET-CT. What does this mean? That if it is negative, then 96% or 79% in PET-CT, it would be positive it would be negative for neck node metastasis. So you are left with a certain percentage that you'll have a false positive or a false negative. So when do we do neck dissection? Obviously, if there are nodes, and Weiss says that you have a 24% chance of neck node spread. So let's now go now to the cervical lymph node groups. Okay, you know this, but just a review, level 1A, level 1B, and then you have 2A and 2B, which is the separation is that of the spinal accessory nerve, level 3, level 4, 5A and 5B, 5A and B separated by the omohyoid muscle, and you have the level 6. Very busy slide, but I just want to mention to you some of the lymph node groups. Of course, the very popular submandibular gland, which lymph node group is usually removed. This is level 1B in oral cavity, and these are the borders. Okay. And normally this would be the usual suspects, primary site, possible site of the metastasis. Okay. And of course, you have the anterior triangle, which is usually thyroid or glottic cancer. Now, in the Committee of Head and Neck Surgery and Oncology in the American Academy of Otolaryngology, way back in 1991, tried to have a standardized terminology of neck dissection, which actually was followed almost all over the world. And then the Committee of Neck Dissection Classification of the American Head and Neck Society revised it in 2001. And this is the conceptual guideline for neck dissection. Of course, we have the radical neck. This is the most radical of all, where you remove all the levels 1 to 5, and that of the SCM or the sternocleidomastoid muscle, and the IJV, which is the internal jugular vein, and the spinal accessory nerve. Now, when you say it's a modified radical neck dissection, you remove all the nodes, the 5 levels, 1 to 5, but you preserve 1 or more of the non-lymphatic structures. Okay. You have type 1 is if one is removed, type 2 if 2, and then if you preserve the 3, then it's type 3. Selective neck dissection, this involves preservation of 1 or more lymph node groups. As in oral cavity, where just remove, if it is an NO, you remove 1, 2, 3, and that becomes a selective neck dissection, in which you don't remove the non-lymphatic structures like SCM, IJV, and the spinal accessory. And extended, if you go beyond the areas where you do radical neck, then that becomes an extended radical neck dissection. Again, a busy slide, just want to show you what are removed in, for example, a modified neck dissection, C levels 1 to 5, plus or minus SCM, IJV. And so you have a type 1 where the spinal accessory is preserved, type 2 when IJV and the spinal accessory is preserved, and when you preserve all, including the SCM, that becomes type 3. So this is the limits of dissection. Well, more or less, you can read it in your book. It's a very busy slide. Just suffice it to say that in the supraomohyoid neck dissection, the border is, of course, the border of the mandible, the superior belly of the omohyoid inferiorly, and this one's, okay, right. And this would be the indications, okay? So you do a radical neck when you have extensive lymph node metastasis with extracapsular spread, modified cross-visible lymph node, okay, but not infiltrating the non-lymphatic structure, meaning it's not infiltrating the SCM, IJV, and the spinal axis. You do a modified, and you have the group of supraomohyoid neck dissections, okay, an extended radical. And there's also what we call an extended supraomohyoid, where you remove 1 to 4, and anterolateral, where you remove 2 to 4 and 6, mainly for thyroid. So in 2001, it was modified. Radical neck was the same. MRD was the same. SND, you put parenthesis. This is the modification 2001. You put parenthesis to denote levels and sublevels. So for example, you write SND 1 to 3. This is the equivalent of supraomohyoid neck dissection. You say SND 1 to 4, it is an extended selective neck dissection. And then in 2008, the modification was, well, basically it's all the same, but they added level 7, which is the anterior superior mediastinal group of nodes, okay? So I just want to ask you this. Based on the American classification, how would you classify neck dissection wherein you remove 1, 2, 3, and remove SCM and IJV? Is it a selective neck? No. Is it a modified radical neck type 1? No, because yeah, it's only the spinal that you removed in type 1. And is it an extended supraomohyoid? No, because you didn't remove level 4. So what is the answer? Maybe it's none of the above. So this is when, but this was already kind of also in way back in 2010, they have proposed this already. And you could see the great names here of the group that proposed this. Of course, you have Ferlito, you have Medina, you have Ashok, you have Jatin Shah, in fact, and all the rest of the great men in head and neck. So why did they propose this? Because mainly there should be because there's the need for to agree on an international nomenclature for cervical nodal groups and neck dissection, which is logical, unambiguous, precise, and easy to remember. So the recommendation is this. You put ND, which connotes neck dissection, and if you want to identify as left or right, then you put L prefix. So you put it in the first. So you say L, and then ND, if it's left, and then R, and then ND, with a space to identify which side of the neck was operated on. And then you have a second component which talks about the levels and the sublevels removed, and you use Roman numerals, okay? So for example, if you remove 1, 2, 3, so you have in parentheses 1-3, okay? And the third component would be the non-lymphatic structures removed. For example, you remove the SCM, so you now have an ND 1 to 3 SCM. So you remove SCM. If you remove the IJV, then you just say ND 1 to 4, for example, IJV, okay? So this would be on the right would be the nomenclature recommended by the American Academy, okay? Radical neck, modified, etc., etc. SND, 2 to 3. And it's equivalent in the proposed international, well, that time was still 2010 proposed one. But I don't know whoever is using this now. We are using this in both my institution. And so the radical neck becomes an ND 1 to 5, SCM, IJV, and cranial nerve 11. which is very, very descriptive. And take note that this one in the 2 to 4 with SCM removal doesn't have a corresponding name or nomenclature in the American Academy. Same is true if you have done 1 to 3 and removed SCM, IJV, and the cranial nerve 11, there is no counterpart in the American Academy and other things. That's why this gets to be more descriptive, and you are able to define or describe what you have really done in your patient. And whoever reads it will understand what you have done to the patient. So we go back to that question that we posed earlier on. Based on this, the American classification, wherein you removed 1, 2, and 3, and removed SCM and IJV, the answer is obviously none of the above. So based on the classification by Ferlito, it becomes in the 1-3 SCM and IJV because you've removed SCM and the IJV. So this gets to be more practical, and you can understand it better what the surgeon has done in the neck dissection that he just did. Now I'm just going to run through you a technique which I mainly for the residents, and this is an ND 1 to 5, a modified radical neck dissection type 3. So this is the development of the flap, and obviously you have to preserve the marginal mandibular nerve. And this was done by my fellow way back, Dr. Warren Holgado. And it's just to show you the dissection of the level 1A, and we are now starting to dissect the level 2B. And this is the level 2B now being dissected. You have the submandibular gland there. And if you have resected it all, then you're able to see now the hypoglossal here preserved, and they have the lingual nerve, okay, and the mylohyoid being retracted there. Now, after doing that, then you can start dissecting the fascia, investing fascia of the anterior of the SCM, and you start with the anterior border and move it forward, and then also the one at the back. Professor Boca would always describe this as creating a butterfly, you know, when you do this kind of a dissection. And so this is the investing fascia in the posterior, which is being removed, including all the structures in the posterior. And that's just to show the greater auricular nerve. And you have the Erb's point. That is the point where, you know, 4 of the muscles, the nerves come out, greater auricular, lesser occipital, transverse, and clavicular nerve. And approximately that is where underneath would be the trapezius, the spinal accessory nerve. And there you are, when you lifted up all this fascia nodes in the posterior triangle, you will be able to see the spinal accessory nerve just close by to the greater auricular nerve. You must remember that the spinal accessory nerve has a branch coming from the first spinal nerve, and that's why it's called the spinal accessory from, you know, the cranial nerve, and you have this one. And before we did a study where we just cut this, if you have big nodes here, we just cut the spinal part, and then we are able to preserve the function of the trapezius. And moving forward, so that's the brachial plexus being shown here, and the omohyoid is being retracted there, and you could see cleaning out level 5B and also going up to level 5A. There you are. And now we are now at the anterior to the SCM, and you could see there the spinal accessory nerve, which divides level 2 into level 2A and level 2B. You remove this if you have very obvious nodes here. Okay, dissection of level 2, preservation of the spinal arch. And here we dissect now the fascia from that of the IJV, internal jugular vein. And there you are. That is more or less the finished product. And just to show you the different structures, the very busy slide, you see all the different structures that are preserved. There you are, and you have the different triangles, okay? Okay. And the lymph node groups, which is 1A, 1B, 2, 3, 4, 5, and this is the 6th. Okay, so this is just to show you a finished product of modified radical neck dissection. And then showing you some of the other vital structures that are to be preserved, obviously the carotid, vagus, and the phrenic. Yes, so if you go back to the classification, just a reminder, the radical neck dissection would be ND 1 to 5, SCM, IJV, and CN 11. And you have a modified neck dissection type 1, ND 1 to 5, SCM, and IJV. And supraomohyoid dissection becomes ND 1 to 3, and lateral neck dissection is ND 2 to 4. And posterolateral neck dissection is ND 1 to 5, and anterior neck dissection is ND 6. So to conclude, great men from Cocker, Kreil, Hayes, Martin, Suarez, etc. contributed to the development of neck dissection as what we know it now, and that's what and how we do it. Classification and nomenclature of neck dissection continues to evolve. There is a compelling need to agree on an international nomenclature for neck dissection, which is logical, precise, and easy to remember. And I think the proposal of Ferlito is very precise and very easy to remember, and it's very, very descriptive. So I'd like to go back to our retiree, Professor Sheng-Po Hao, and I would like to call him a consummate man on a mission. In fact, he actually single-handedly organized the Asian Society of Head and Neck Oncology. We got to meet in Pattaya a year back, and he mentioned to me about this. And I said, it's okay, we do this. And in July 2008, he organized all the different head and neck surgeons in our area. And we met in San Francisco, AHNS, and that's where we organized it. So I call him a consummate man on a mission. So with that, I'd like to thank you all for your kind attention. Thank you very much. I'd like to stop here now.
Okay.
Yes.
Thank you, Professor, for this wonderful and comprehensive talk about neck dissection. Now we open to the floor if any doctors have any questions or discussion.
Any questions?
Maybe I have a question.
Yes.
How many of the audience follow this classification?
Well,
A raise
yes.
of hands? Yeah.
I find it very interesting. And actually, we have done it, although we don't use the name.
Yes.
Yeah, we have done it, although we don't use the name, exactly like what you mentioned for international scientific group. Yeah, and but actually we have done it. For example, we will write down a modified, write down a supraomohyoid neck dissection, but then sacrifice for example, the part of the sternocleidomastoid muscle or even the internal jugular vein. We will specify that. Yeah, but I think it's the nomenclature, the classification is much more details, and then allow everybody could follow, and I think that's very schematic and to
Yes.
record everything. And I certainly agree with you, and I hope we may start to adopt on the classification, and yeah. Thank you so much for.
Maybe you can propose this in Ashno. I know that,
Yeah, we
I know the
should.
Japanese, they have their own. I didn't put it already, but
Yeah.
I started it a little bit more complicated. This is simple, right? Very simple.
Yeah, this is
Yeah.
actually very simple but very comprehensive.
Yes,
You
and very
won't,
comprehensive. Yes. You
there
won't
is.
miss anything. And you don't uh put some things in imagination. Did you remove this or not? You're not sure.
Yeah.
But in this one, you can really see everything.
Yeah.
Describe
That's
it.
good. That's really good. I really enjoy your lecture, and
Thank
you know,
you.
actually, I look at your slides. The neck dissection slides. It's very clear and also very comprehensive. And
Yes.
congratulations! It's certainly
Thank you
a
to my fellow,
something
yeah,
like a
Warren.
textbook.
Yes.
Yeah.
Yes.
Yeah, very, very good technique, and and all the details, and yeah.
Yes.
And neck dissection is what we do every day.
Oh, yes, that's
So
true.
yeah, so what we do every day. So that's goes to the basics of our
Yeah.
head and neck oncology surgical technique. Yeah, and I think that's probably the most important thing.
Yes.
And
I was joking when I was in Indonesia. The
yes.
resident was bringing me home. I said, I get sick if I don't do neck dissection. He said, "Oh, really, doctor?" And she started to believe. Then I laughed. I said I was just joking.
Yeah.
But that neck dissection is really basic. For a head and
Yeah.
neck. Yes.
Yeah. Well, nice to have you, to give such a wonderful talk, and I really want to thank you for your compliments on me, and starting from a man of his words. That's many years ago. Yeah, that's from you also, a man of his words, and then now a man of mission. And I thank you so much because Alfredo, you and me are not only by myself. I think nice to have your support, and we work
Yeah.
together, and we work together, and shoulder to shoulder, hands to shake hands, and to build up the Asian Society of Head and Neck Oncology.
Yes.
And I think we have done something. Yeah, right, Alfredo. Yeah, I
Yeah.
think we really have done something for our part of the world, and
Yes,
I'm really
yes.
very honored to be able to get this done with you. Thank you, Alfredo.
Yes.
Yes.
Right.
So if there isn't any more questions, I'm going to end this, Professor Alfredo Pontejos lecture, and just to give you some advertisement for what we are going to have in May. In May, we still have 4 lecture series from Japan, Professor Hirano, and from Shinha, United States, and Pankaj Chakravarti from India, and then GoBC from Malaysia, and look forward to all the participants, log in in either Tuesday morning 7:30 or Monday morning 7:30 every week.
Yeah.
So and thank you so much for all the support, and especially for your wonderful lecture and also your friendship. And so have a good day, and send my best regard to Harin. All right.
Yes. Yes, I would.
All right.
Right.
Yeah.
All right.
So yeah, that's for the day. Well, thank you.
Thank you. Yes.
Yes. Yes.
Okay.
Really
See ya.
nice, Alfredo. Really, really nice, as always. You
Thank
really
you.
win my heart. Your lecture is just, in 20 minutes. And you talk about everything, and it's so comprehensive and so clear. You know,
Yes, I timed it, so I will not exceed, that's why I cut some slides, so, yeah, so I reach 25 minutes, yeah.
yeah, yeah, but I think it's really good. It's really good. Yeah, as always.
Yeah, and
Right.
we have a lot from the Philippines attending, yeah.
Yeah,
Okay.
yeah, and then we will record your lecture and put it on YouTube.
Oh, yes.
And then I think your lecture is really good for all the beginners. Even for some experienced surgeon like me, because I never heard about the international scientific group nomenclature classification. But I think especially for the beginners, which is really something. Yeah. Thank you. All right.
Okay.
Have a good day.
All right, see you then. Bye-bye. Yeah.
Bye-bye. Yeah.
Bye. Regards to Helen.
哇，
哦耶，今天很高兴啊，我看你。
对啊，对啊，那个 Alfredo 讲的很好，他讲的很好，他好朋友啊，好朋友，他讲的很好，对，他是很准备的，很那个的，有用心准备的，所以是，好吧，好吧。